And let's talk about kind of interpreting those results. So you get the catheter, everything in place, and I assumed it's hooked up to some sort of monitoring device. So they just kind of clip that on their belt or their shirt or something.
Yeah, it's kind of like a little messenger bag purse type of thing that they have that's continuously recording. And then patients have the ability to press buttons based on symptoms. So there's a button for, you can program it for 3 symptoms that they might be having. So they can press when they have the symptom. And then they can also press a button when they're starting a meal, laying supine, that sort of thing. So for about 24 hours, it's continuously recording. Patients come in the next day. The nurse is able to just remove the catheter, just make sure it's still taped in place and that it didn't shift. And then we take the recording. There's programs that come with it, which will kind of plot out the pH and then timestamp it for symptoms. And so the program is really helpful because it does all of that plotting for you. And then you can look at how many kind of reflux events the patient have. We have some normative data from GI, which again is primarily based on distal esophageal reflux events, but we do have some for, the pharynx. The tricky part about where this gets to not being a perfect test is the idea that, like, what if there is no correlation, but you see reflux events, right? For GI, for GERD, they consider that negative if there's no correlation. With ENT or laryngology, we're a little bit softer on because we do know that there's a neurosensory network. So I usually look for any sort of events. The correlation part I'm not as concerned about because if people are having LPR events, yeah, an hour later they could have throat clearing, right? There's a little bit of a temporal delay in throat symptoms as compared to heartburn. So I'm looking really for any type of reflux events. If there's correlation, fantastic, but often there just isn't that exact correlation.
Does it break it up between acidic and non-acidic events?
It does. That's why I like the pH impedance probe because I tell patients it will tell me about your lower esophagus and upper, and it'll tell me if it's acidic or not, and then it tells me if there's any correlation. So it does provide a lot of information. Again, the alternative would be an empiric trial. So it provides a lot more information than us just looking with the scope.
And then what do you do with that information? So once you have established that a patient is having reflux events, whether acidic or non-acidic, does your treatment look similar to what your empiric treatment was going to look like, or is it different?
No, definitely. So if I see a lot of abnormal amount of acid, then I know this patient should be on an acid suppressing medication. If we see a lot of non-acid reflux, then I usually talk to them about the alginate suspension. And for both of these, if we're seeing a lot of reflux, then it kind of encourages patients. I'm like, listen, there's a lot of kind of dysmotility or something happening here contributing to this reflux. By the time that they come for the testing, most of these patients have already tried the diet, behavior. They're very strict about it. So if you're still having a lot of dysmotility, then we probably need to add further testing in that way with regards to motility testing. We need to get our GI colleagues involved. And I even refer some patients for surgery, for reflux surgery, if we see it there.